Hello, I'm Dr. Jenny Andrus, and welcome to Joint Ventures. In this OSC original podcast, we take a hard look at recent medical news and headlines. We know medical news can be difficult to understand, and it's hard to know which sources you can trust. Do you trust the nightly news? That Facebook post? The commercial constantly telling you to talk to your doctor about their new drug? Our goal with this podcast is to review the latest medical news and trends in a non-biased way and to present it in a format that's understandable so that you can make informed decisions about your health. If you're new to this podcast, welcome. We're so thrilled that you decided to tune in. For those of you newcomers, I'm an interventional pain management physician at Orthopedic and Spine Center in Newport News, Virginia. Back pain is the bread and butter of my practice. While I try not to load my patients up with pills, medications are inevitably a part of back pain treatment. Antidepressants have long been a staple in the pain management arsenal for neuropathic pain. And in the last 20 years or so, antidepressants have also been a staple in the treatment for spinal pain. Many medications are given for multiple conditions, so the fact that a medication prescribed for mood could impact pain shouldn't really be all that surprising. But do they actually work? I mean, do antidepressants reduce back pain, improve function, improve outcome, or any other marker that a patient or a doctor would actually care about? The Cochrane Library released a recent review on antidepressants and low back pain. Now, you may have heard that name before, Cochrane Library, Cochrane Review. People tend to throw it around like it's the Supreme Court. It's definitely not that. It is not the definitive last word on anything. It is a systematic review of available published scientific literature. They use systematic methods aimed at reducing scientific bias to produce reliable findings. Their methods are clearly stated, and they try to synthesize and appraise studies in aggregate. They focus on healthcare and regularly update the reviews. All of this is very good, and you should pay attention to what they find. Cochrane is considered the gold standard for systematic reviews. But these are reviews, which means they are taking a collection of studies and using a standard way to appraise the study's quality and then synthesize the findings. So basically, they're saying if a study quality is good or not, and then they're looking at the findings of those studies as a group to see if they can answer a specific medical question. So in this case, the question is, do antidepressants help with back pain? We're going to go through this in detail, but keep in mind the concept of junk in, junk out. The Cochrane Review is only as good as the studies it's reviewing. Pain is a particularly difficult thing to measure. It is extremely subjective, and so we often tend to look at function instead. And even though the functional outcome measures used in these studies have been validated, they are in some cases also quite subjective. I have patients who walk into my office without any difficulty, but they say their pain causes complete difficulty with walking. Well, not really, right? I mean, they're walking on their own. But I have other patients who come in on a walker and they say their pain is causing minimal difficulty with walking. You see what I mean? Self-reported data is subject to interpretation. One person's 10 is another person's 1. This hampers pain management research and has to be considered. Additionally, we have to keep in mind that the absence of science to prove something works or doesn't work doesn't mean proof that the thing works or doesn't work. Okay, follow with me here. In a court, a person isn't found innocent, they're found not guilty. That doesn't mean they didn't do it. It means there's no proof to show they did it. So we want to see proof, however, before we put a chemical with potential adverse effects into our bodies, right? I would. Now, before we get too far into this review, let's just chat a minute about how antidepressants work for pain. You might have heard recently the whole concept of chemical imbalance was kind of thrown on its head when not too long ago it was revealed that we actually really don't know how exactly antidepressants work. Whoops, right? Yeah, I know. Me too. I remember my pharmacology classes in medical school, and I remember learning that antidepressants work by increasing levels of serotonin and norepinephrine and adjusting some neurotransmitter imbalance. Okay, that may or may not be the whole story, and not knowing exactly how they work doesn't mean that they don't indeed work. We do know that pain and emotion are processed in some of the same areas of the brain, so it would make sense that a chemical that impacts emotion could impact pain as well. The current thought is that antidepressants cause neurotransmitter changes, which influence the descending pain pathway. Pain is complex. Signals go from the body to the brain and then back down from the brain to the body. There is a pathway that dampens that pain signal, and that's called the descending or inhibitory pathway. There are probably other ways that antidepressants modulate pain, including effect on sodium channels. And now studies have been conducted to look at antidepressants' impact on pain exclusively, and that's what we're talking about today. But you should note that depression worsens pain and pain worsens depression. So there has to be some credence given to the idea that improving depression also may improve someone's pain. That being said, the studies we are most interested in are looking at pain and would exclude people with clinical depression. So what did this recent review show? Okay, well, this 2025 review was an update to the 2008 review. They included 26 randomized controlled trials that compared antidepressants to placebo, usual care, or no treatment at all. Patients were adults with low back pain or spine-related leg pain of any duration. Primary outcomes were pain intensity and disability, and adverse effects and quality of life. Those for sure what matters to me and to my patients, so we're off to a good start, right? The follow-up period for these measures was really short, 4 to 14 weeks. And sure, when you're in pain, that might seem like a lot of time, but when you're taking medicines that have to be started low and titrated up, this isn't very long at all, especially just 4 weeks. So I can't conclude from this anything about a longer-term trial. I can just say what the effect there is in a relative short-term period of 4 to 14 weeks. Most of the patients included had chronic pain of greater than 3 months. Mean age was 27 to 59. There's a hiccup right there. Most back pain patients are over 60, so keep that in mind. Also, these weren't looking at the same medicine. 8 studies used SNRIs like duloxetine, 2 used SSRIs like sertraline, and 14 used tricyclic antidepressants like amitriptyline, and 4 other studies used really much more esoteric, less commonly used antidepressants. And here we have another issue. TCAs are routinely used for sleep, neuropathic pain, conditions with diffuse pain like fibromyalgia. The data, particularly on neuropathic pain conditions for TCAs, is quite good. I've been in practice for 15 years and a doctor for over 20, and during that entire time, I have seldom ever used a TCA for nonspecific back pain. Maybe I've used it for sleep or another condition in combination with back pain, but not really for back pain itself. I've never used an SSRI for back pain. SNRIs, on the other hand, especially duloxetine, have been used extensively. So I like that 8 studies included SNRIs, but the bulk of the studies included medicines that I would never even consider for nonspecific back pain anyway. So what did they find? First, SNRIs, the drugs I would prescribe for this condition, demonstrated with moderate certainty evidence, meaning kind of medium quality, that they have small effect on pain and an even smaller effect on disability. The evidence for spine-related leg pain, or that sciatica pain, was uncertain, but the data was poor quality. SSRIs had no effect on pain or disability in low back pain with low certainty evidence or poor quality evidence. There was no effect or evidence to determine its effect on leg pain. TCAs, or tricyclic antidepressants, had little to no effect on pain and small effect on disability, with moderate evidence for back pain. TCAs had a large effect on pain and a moderate effect on disability for spine-related leg pain. The quality of this evidence was poor, but it's in line with what we would expect, as TCAs have a good evidence for benefit in nerve pain. Now, I know you guys have heard the end of that pharmaceutical commercial where they mention every horrible side effect known to man. They say them all really quickly at the end, while the recently healed person rides their bike with their family and their sad mask face turns into a happy mask face. So there have to be some adverse effects in these studies, right? And of course there are. There are moderately certain evidence that SNRIs probably increase adverse events, but unclear if any of these were serious. Data quality was too poor with TCAs and SSRIs to determine. We know that the side effects with antidepressants are common and include blurred vision, drowsiness, dry mouth, nausea, vomiting, weight gain, constipation, urinary retention, sexual dysfunction, heart rhythm problems, and lightheadedness upon standing. Do I sound like the commercial? These are typically worse as the dosage is increased, and they may develop over time. TCAs are really the most egregious, and their side effects are more pronounced in elderly patients. So what's the answer? Do antidepressants work for pain? There clearly isn't enough data here to say they are dramatically beneficial. The data is really hampered by the relatively short duration of these studies. This review honestly just reinforces my prescribing pattern, which is SNRIs, particularly duloxetine, helps with back pain with usually pretty tolerable side effects. TCAs like amitriptyline help when there is a more clear neuropathic quality, but with more side effects. I don't mess with the rest of them because they don't have evidence that they help, either in studies or by my clinical experience. I also wouldn't use antidepressants for nonspecific low back pain as a first-line treatment due to side effects and lack of strong evidence of benefit. Clearly, we need better studies going out, more like maybe 6 months or so, to actually address benefit. Thank you so much for listening. At OSC, we have a long history of patient advocacy and education, and we're so grateful for this opportunity. Please consider subscribing to this podcast. We don't want you to miss out on any of our further discussions. Thank you again, wishing you good health, and see you soon. Bye-bye.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and